Now, the secretary report by Dr. Ubal, and then subsequently Ubal will take over and conduct the clinical pathological conference also.
Good evening, welcome all. As upgraded as our website and the online registration as well as online payment is updated. So anybody who is not yet registered, they can register, particularly the PGs, and they can pay the fees also online. And in the website, we started two interesting articles. One is from Learning from Legends. I think Professor Krishnan has initiated the initial article. So please visit the site and read the article. The other aspect I want to highlight is the other side of gastroenterology. I want to promote what the gastroenterologists are capable other than gastroenterology. Dr. Radha has written a beautiful article in Tamil. So whoever interested, please visit the website. And also suggest some of the ideas how to improve the website further. And we got the new member, Dr. Shankar, is a surgical gastroenterologist from Ramchandra. And Professor Jayanti has asked for an ethics committee. I had some output from, again, a Cipla company about the role of ethics committee for a society. It is possible. I think we can discuss at the dinner meet how to go about it. And there are some money involved, and each meeting, I think we have to spend some money, and we can look into that. And next Sunday, there will be a World Hepatitis Day. I request all the consultants who are working in the institutes to promote this year's theme will be Find the Missing Millions. That is to look out for the patients who have hepatitis C and B. And the aim for eradicating hepatitis C is for India is 2030. I think Tamil Nadu at least we should aim for 2025 to cure for hepatitis C and advocate vaccination for hepatitis B. That is the main mode of prevention of hepatitis B. And coming to today's topic, I thought we are exploring different aspects of learning. And CPC, I always fond of presenting a CPC in an audience, but mainly to interact with the PGs. So there is one area we can learn from a particular case. You know that all the previous 4 cases are different cases. This is also one of the cases. I request the first 4 people, that is Dr. Girish and Assis, to come over, and Dr. Preeti and Basumani, who will be guiding the PGs. And I also thank Dr. Surya Kumar, who is the first one, I think, who initiated PET-CT in this part of the country, and Dr. Vikram Raj, pathology. All these 6 people are not aware of what the case I am going to discuss. I think so, mostly. And 3 mosquitoes, that is all for one and one for all. These people, they know the case, actually. So 2 of them are here, and I think they will be talking at the end. I present as how it has happened as a story, because it is not what I was sent as a CPC. So it was happened like that. I am doing a procedure in endoscopy. My secretary came and said, "Sir, one patient is referred for an ERCP from an oncologist. It is advanced CA pancreas. They advised for a metal stent." So I said, okay, usually the secretary is very excited. If somebody's patient referred for ERCP, whether I get excited or not, the secretary will get excited. And he said, I'll arrange for the ERCP. Because I was busy in a procedure, he said, I'll take everything. After some time, he came back and again and said to me, "Sir, the attendant is asking so many questions. So I cannot do anything about that. You do something." So I said, send the patient to my OP. So he said, I am sending the attendant to my OP. So the patient, attendant came, I thought he's an attendant. He came to my room and asked so many questions. What is the ERCP and what is the stenting? And what is the metal stent? What is the plastic stent, etc. She's keep on asking questions. So I somehow worried why she's asking so many questions. Then I asked, because my secretary told me that I am sending the attendant. So I asked the lady, please bring the patient. She said, I am the patient. So she's a young girl, and because somebody referred to me as an advanced CA pancreas for a stenting, suddenly I'm looking at a young girl, and I am really worried that whether she's really needed for a metal stent. So my I convinced her that you need this procedure to reduce the jaundice so that they can plan some kind of treatment. So we proceeded with the ERCP, and it is not easy. It is a difficult procedure. And after a pre-cut, we are able to cannulate the CBD. And anyway, we don't inject much contrast whenever we suspect malignancy. So there may not be much input from the ERCP. So because there is a long segment lower CBD stricture, as well as we did a brushing and stenting. So ERCP finding will be a long segment narrowing in the lower CBD, biliary sphincterotomy, brush and stenting stent. So I'll ask the PGs how to proceed next. Patient who referred for an ERCP, and ERCP showed a lower CBD stricture. What are your thoughts? If the PG is anything trouble, and Basamani and Preeti can help.
With lower CBD structure, I would like to know first this, sir, history. What is the history, what's the duration of
No, leave alone that. Somebody is having a lower CBD stricture. How to classify further? What is your thought? What will be the causes for the lower CBD stricture?
I'll check whether it is benign stricture or malignant stricture.
Good.
So,
Benign, what are the things you are thinking of?
sir, if it is a benign stricture, I'll think of whether it is chronic pancreatitis induced stricture, or it is because of some post-surgical stricture, or it is because of autoimmune pancreatitis, or IgG4 related sclerosing cholangitis, or any infection like tuberculosis, histoplasmosis, and HIV-related cholangiopathy in that MAC infection, Mycobacterium avium complex infection.
Malignancy?
And in malignants, I'll think of periampullary malignancy involving CA head of pancreas, ampullary carcinoma, distal cholangiocarcinoma, this malignancy, or lymphoma causing extrinsic compression over the distal CBD.
Metastatic disease outside the nose. Anything else? Basamani, Preeti. Others also can contribute, because I am seeing a lot of surgeons and gastroenterologists, endoscopists. Any rare cases where you see a lower CBD stricture, the diagnosis may be different, not the conventional one. Anything, Preeti, Basamani, sir? I think they covered everything. So these are the common reasons for lower CBD stricture. So the brushing, I will come back at the end of the slide. And so before coming to me, see, 7 days ago, she was seen by an oncologist, that is in Apollo. She's a 38-year-old female who diabetic for 3 years and had lost weight about 40 kg in the last 1 year with a loss of appetite. She also complained of oily stools, but it was not documented as a steatorrhea. She recently developed jaundice, which was progressive, not associated with any other cholestatic features, and no pain abdomen. These are the salient features of history she has given to the oncologist. Her height is 55 kg, weight is 157 centimeters. She was mildly icteric, no cyanosis, pallor, or clubbing. And she had, in a general examination, she had few axillary as well as inguinal femoral nodes. There are multiple discrete. Largest in the inguinal node, which is measured about 3 to 2 centimeters. The temperature, pulse rate, blood pressure is normal. All the systemic examination was normal. So what is your thoughts, Girish? So this is the short history.
Good evening, all. So this is a 38-year-old female. I'm just telling a short summary with a probable exocrine endocrine insufficiency in the form of diabetes and oily stools. Probably we can take it as steatorrhea. We didn't get the other history, like whether it is loose, bulky stools. We can take it as steatorrhea. So it's a maldigestion process. So we can consider the probable as pancreatic pathology with chronic pancreatitis. And the patient had significant weight loss with a progressive jaundice, likely to be extrahepatic cause because there is no fever or any prodrome. So, and along with generalized and abdominal lymphadenopathy. So with this, I can say about the differential diagnosis. So chronic pancreatitis with a distal CBD stricture. In that, one etiology could be an autoimmune pancreatitis with IgG4 cholangiopathy, because the patient, usually autoimmune pancreatitis present with obstructive jaundice, and there is other system involvement in the form of abdominal lymphadenopathy. But the odd point against this, the age group is slightly on the lower side. Usually it
Sex.
presents more than 6 decades.
Sex also, no?
Six.
Male, predominantly male.
Male predominance also. And the other possibility with such a short history with weight loss, loss of appetite, and a short history of jaundice, one would consider a malignancy. CA pancreas, probably a chronic pancreatitis going on to a CA pancreas. That will be the second possibility. Other possibility with history of obstructive jaundice with lymphadenopathy, pancreatic lymphoma is other possibility which can present with obstructive jaundice and generalized lymphadenopathy with abdominal lymphoma. But that too, the age group is usually above 60 years. And it's a male predominant, and it's very rare diagnosis. And to call it as a primary pancreatic lymphoma, there should be no superficial lymphadenopathy. But here there is superficial lymphadenopathy. And other least possibility I would like to keep is pancreatic tuberculosis. Because it can again present with acute or chronic pancreatitis, obstructive jaundice. But the usual presentation is abdominal pain in this patient. So these are the differential diagnoses I would like to add.
Other PGs, anybody else also can contribute actually.
With these differentials, if we would like to get a more history regarding basically her high-risk behavior, then history regarding any exposure to drug, then any other complementary alternative system, any post-surgical history, that history I'd like to take. So any high-risk behavior, we could think of more common of lymphoma or SIV-associated cholangiopathy. Then one more will be IgG4 related. If we are suspecting autoimmune, some autoimmune etiology like previous history of some autoimmune disease, joint pain, rash, arthralgia, or and age, basically her age is 38 and that too female. Unlikely IgG4, it is usually male predominance disease. So
Anything else? I think that's what even I thought of. Because we never had discussion, because what Ashish or Girish is saying is same as what I thought of also. And also I thought metastatic disease with unknown primary. This is mainly because the oncologist referred, that is a disease you always, this is the investigation we got, that is, it was done by an oncologist, and hemoglobin is 11, and sugar is 236, and HbA1c is 7.7, and renal function is normal, and bilirubin is 4.9, pancreatic enzymes fairly normal, and alkaline phosphatase is 468, CA99 is 119. Other tumor markers, CEA, beta HCG, CA125 are normal. And serum protein, except for a low, mildly low, age reversal, but albumin is normal. And IgG4 was 1240, and protein electrophoresis showed an oligogonal pattern of IgG. So these are the investigation we have.
So, from this investigation, sir, in liver function test, there is obstructive pattern of the picture with bilirubin 4 and raised alkaline phosphatase and GGT with mildly elevated AST and ALT. With increase that IgG4 is 1200 with serum electrophoresis showing oligoclonal pattern. So here we are only having that obstructive jaundice picture. Otherwise, in CBC, everything looks like okay. This unlikely to be IgG4 because IgG4 for diagnosis it should be more than 1.6 gram per liter, and that pattern should be polyclonal rather than monoclonal. Then I like to have viral markers in this. There are no viral markers available at HBsAg, HCV, and retrovirus. So these viral markers are lacking. Then we don't have GGT also here, sir. So if it is GGT also increased, then we can think of some infiltrative kind of a disease, more of lymphomas. So GGT is not available. And in alkaline phosphatase also, if we get an isoform of alkaline phosphatase to quantify whether there is some hematological malignancy or primarily of hepatic origin, we can think of that.
Viral markers were next.
Sir, IgG4, sir, usually it should be the normal levels in Indian labs is less than 1.5 gram. So if for diagnosis, if it is more than 1.5, we can think of IgG4 related disease. But sometimes the specific cutoff is 2.4 gram per deciliter.
May I know where you got this reference from?
Um,
Because I've seen about 150 IgG4 cases in this place. And you're talking about the serum IgG4 level.
Yes, sir,
am I
serum
right?
IgG4.
It can't be done in the tissue.
yeah, serum IgG4. level.
One important point, it is more than 135 milligrams per deciliter. That is the cutoff point. The second important fact is there is no absolute Indian data with respect to the cutoff point as far as this country is concerned. And elevated serum IgG4 is not just pathognomonic of IgG4 disease. You can have situations when a patient has got IgG4 disease demonstrated by histopathology, but the serum IgG4 will not be elevated. It depends on so many factors, like one is the extensive progression of the disease, because you can just have a unicentric IgG4, you can have a multicentric IgG4. So it depends on the distribution of the disease. And number two, it also depends upon the activity of the disease also. So now what happens is a lot of controversy, whether she should serially estimate serum IgG4, whether a person is responding to treatment or not. So the first important point is, please, I think you have to erase the thought out of your mind that a cutoff point for serum IgG4 is not what you said, but in journals and textbooks and what is accepted all over the world is a level of more than 135 milligrams per deciliter. Sorry.
Ashish, for your information, he is Dr. Ramakrishnan. He is one of the authority in IgG4 disease in India. So whatever he says, please accept it.
I was going to intercept. Yeah, I think IgG4 is the least of the IgG classes. No, IgG4 is the least value. So we are not talking about grams here. So that's one thing. Second thing is even in a classic 60s man with bone door clinical disease, the prevalence is only 70% raised IgG4. So serum normal IgG4 does not rule out the disease. And as the legend said, the activity and various correlates. Lymphoma, chronic infections, HIV, so many conditions can raise IgG4. So it's neither specific nor pathognomonic. So that's the.
Well, I'd like you to just please help me on this ground, that you kindly call up my wife and tell her that she has to also listen to me. Thank you very much, Well. But I should also tell that to your wife tomorrow morning.
Hey, Sankit.
Sensitivity is reduced, but if more than 4 times upper limit of normal, for example, if values 8 to 135, as per the literature, the IgG4 level is 8 to 135, but if more than 4 times, the diagnostic accuracy is significantly high. Here it's pretty high.
Whenever you have more than 5 or 6 criteria, it's not.
You cannot use it as an isolated criteria. That is the take-home message actually. You can't harp about it.
Other organ involvement is also there. And
When we say pathognomonic, if you see AFB in a gaseating granuloma, that is called pathognomonic. So when you like SLE, rheumatoid, or IgG4 disease, when you have 4 criteria out of 4, then you are talking about probable. So the final word has already said.
That is why they say as definite, probable, and possible. What is very important is the histopathology.
Even histopathology, they have level 1, level 2. Like in autoimmune hepatitis, whatever the inflammation criteria you have, you need histology for definitive. Whatever the score may be, whatever the rise of score may be, the definitive comes from the pathology. Okay.
Ashish, you don't give any significance to CA99?
CA99 has been raised in any type of obstructive jaundice, sir. And to tell it as an malignancy, it should be in thousands, sir, usually. So in only this CA99, after clearing the obstructive jaundice, during follow-up, we can see of otherwise.
What is CA99, by the way?
Carbohydrate antigen 19.9.
What is it? So it is a modified Lewis blood group A antigen secreted by expressed on the surface of cancer cells. It is 3 important diseases which is very useful. One is screening for pancreatic cancer, and prognosis for medullary thyroid carcinoma, and lung adenocarcinoma with the malignant pleural effusions. As you said, that it is also associated with other non-cancerous conditions like cirrhosis, pancreatitis, cystic fibrosis, and a lot of other cancers also. And IgG4, as Basamati has said, it is the least subclass of IgG4, constitute about 6%, and it is a sclerosing disease which affects wherever there is a lymphoplasmacytic infiltrates. Common sites are head and neck, salivary glands, liver, lung, pancreatic biliary, abdominal aorta, breast, CNS, kidney, and lymph nodes and ureter. I don't go to the histology. And before this, I think in January 2019, she was evaluated at Calcutta for weight loss. At the time, she didn't have any jaundice, but she went to the gastroenterologist only for the evaluation of weight loss. We don't have any pictures at that time, but I have the reports of CT scan, MRI, EUS, etc. CT scan showed a hepatomegaly with gross fatty changes, irregular wall thickening and dilatation of the pancreatic duct as well as CBD. They mentioned a diffuse lesion in pancreas and enlarged pelvic lymph nodes. MRCP also the same almost. And they did a EUS FNA also that showed no evidence of malignancy. And endoscopy at that time showed a pangastritis. So what is your thoughts on after, this was in January 2019. So I didn't mention all the reports, they concluded as is an autoimmune pancreatitis. I didn't type it out, but they, all the MRI, CT scan, they put an impression as autoimmune pancreatitis.
So the imaging features suggestive of a diffuse lesion of pancreas, which is usually seen in autoimmune pancreatitis. But the odd point here is we have both CBD and PD duct dilatation. Usually in autoimmune pancreatitis, there will be no direct duct dilatation. It is usually stricturous, or it should be like narrowing of the duct is mentioned actually. And there is evidence of enlarged lymph nodes also. So with this imaging only we can suggest a possibility of CA pancreas, because both the ducts are dilated with lymph nodes. So a possibility of malignancy is more in favor of with this imaging. But because of diffuse lesion of pancreas...
malignancy, what kind of? You are thinking adenocarcinoma or something else?
Adenocarcinoma of pancreas.
Adenocarcinoma is very unlikely you have a diffuse lesion, no? Either you have
That's an odd point, sir. Diffuse lesion is more in suggestive of autoimmune pancreatitis.
Sir, here diffuse pancreatic lesion with with other organ involvement in the form of peripheral lymphadenopathy, that too contagious. So we can say that a disseminated lymphadenopathy because two non-contagious lymph nodes are involved. We can't think of some lymphoma or secondary lymphoma involving pancreas. That should be one other, because these diffuse lesions of the pancreas are usually because of autoimmune disease, lymphoma of the pancreas, and sometimes because of diffuse pancreatic metastasis, but that too unlikely. Adenocarcinoma rarely presents as an diffuse involvement of the pancreas, sir.
We need to put in a diffuse pancreatic lesion as well. There are a lot of hard points in this case. So which possibilities will sort of satisfy three or four main
So pancreatic lymphoma or autoimmune pancreatitis in the form of IgG4 related disease.
sarcoid?
Sarcoidosis of pancreas. Yeah, pancreatic sarcoidosis.
What are the causes of oligoclonal? Serum
So we go to bank of IgG4. Probably IgG4.
Please come down to my place.
Oligoclonal bands of IgG4 is mainly seen in IgG4 related diseases actually, sir. All
They didn't say oligoclonal IgG4.
so I'm saying polyclonal is other seen multiple cirrhosis, all those type actually.
So we are zooming in on still autoimmune pancreatitis.
So that's what the doctors in Calcutta thought of, because this is I think Ramakrishna sir can correct me, this is the one disease where you need not require a histology to diagnose a IgG4 disease when it involves the pancreas. If the imaging suggestive of and high levels of IgG4, you can give the option of steroid treatment. There is one organ involvement where there is no requirement of histology. And I think that is the mentality what the doctors in Calcutta started on oral prednisolone in January 2019. But the thing is, she didn't get better, and that's why she came here, and we are continuing with our oncology colleagues. So after the routine investigations, and I think we ordered a PET CT, because he already had a CT, MRI, endoscopic ultrasound, and they thought the PET CT is the next investigation of choice. I think this PET CT is the most widely used investigations. I thought this forum, I request Dr. Surya Kumar, who is one of the initial PET CT in Chennai, I request Surya Kumar to talk briefly about the PET CT in gastroenterology.
Thanks, sir. Thanks, Dr. Upal, sir. At the outset, I would like to thank Dr. Upaldas and the there is a lot of hype about the PET CT in the city nowadays. That's because it is offering more information, not only in the anatomic aspect, and as well as we are also getting information about the physiologic aspects of the lesions wherever we see. This is how the PET CT is being done. Initially, a CT scan is performed, and in the same position, a PET CT is also performed on the same, when the patient moves further inside the machine. Both informations from the CT and the PET gets fused together to get the PET CT information. For the PET information to get, we need to have a radiotracer injected into the body. What is a radiotracer? The radiotracer is the one which emits a positron, which is detected by the machine. The positron which is detected by the machine, it becomes a positron emission tomography. This positron is an atom. Either it's the commonly used positron is an F18 or a gallium-68. This F18 atom cannot be used just like that. It has to be attached to a radiotracer or the ligand. So the ligand is the vehicle which takes the F18 or the gallium-68 to the region of interest. There are multiple radiotracers which are available, which are commonly used. F18 based radiotracers are FDG, NAF, sodium fluoride, F-DOPA, and F-meso. And gallium-68 based tracers are DOTA, PSMA, exendin, and citrate. This F18 stands for the positron emitting atom, and in FDG, F stands for F18, and DG stands for deoxygenated glucose. This is one of the commonest used radiotracers across the globe. This is being used most commonly for oncology purposes, whereas it has also got many other utilities like non-oncological utilities as well. The other tracers are NAF. This is sodium fluoride, which is predominantly used to assess the bone lesions, which is very much similar to the bone scan. And F-DOPA is to study the dopaminergic cells and the neuroendocrine tumors, which is not that widely available. F-meso is to understand the how exactly the lesion will be responding to the radiation or not. And the other commonly used gallium-68 based tracers are DOTA, which is used in neuroendocrine tumors, and gallium-68 PSMA, which is used in prostatic malignancies. These two areas, why DOTA and PSMA used is because the FDG molecule may not be very clearly visualized in these malignancies. Exendin is to look for the benign insulinomas, and citrate is to look for the infections. So coming to the commonly used molecule FDG, this is how it is going to be. F18 is attached to the deoxygenated glucose molecule, and the glucose molecule acts as a vehicle and which takes the F18 to the area of interest. Why deoxygenated glucose molecule? This is because the deoxygenated glucose molecule enters into any metabolically active cells similar to the glucose molecule. But since it is deoxygenated, it cannot enter into the pyruvate cycle and gets locked within the cell. So when a lot of FDG gets accumulated within the cell, we get a higher positivity in the PET images, which is getting fused to the CT information. So this is how it is going to be. So this is a CT image which is giving the morphological information, where the lesion is, how the lesion is. And this is the PET image where it gives where the metabolic activity is higher and where the metabolic activity is lower. When we fuse both these things, we get both informations. It's like anatomic and physiologic information, it's anatometabolic imaging. And the PET imaging is a whole body image, so it gives a complete information of the metabolism of the entire body. This is how the normal whole body PET looks, and the cerebrum will be showing up higher metabolic activity normally, and the liver will be showing a mild metabolic activity. Spleen will not be showing metabolic activity, which will be lesser than the liver. This is a pathological spleen, and hence it is showing a little higher metabolic activity. And deoxygenated glucose is excreted in the urine, and hence the bladder will be filled with the glucose, FDG, and it will be showing up higher metabolic activity. So it's a huge topic on its own. I'm just going to add give few information how exactly, where exactly it is being used. So FDG, I'll just focus on two molecules, FDG and DOTA. FDG PET is increasingly used in oncology purposes for staging of the malignancies, to understand the, if at all, if there is an unknown primary, to understand that type of primary lesion in the staging purposes. And the other important aspect would be therapy response assessment, whether during chemotherapy, how is it responding to the treatment, or following radiation. And another important role is during the surveillance, to look for whether there is any early recurrence or not. The other non-oncological informations which we get in FDG PET is the in PUO. Nowadays it has become a gold standard to look for the inflammatory sites or infective sites if it is not clearly visualized in the routine imaging modalities. And this is because even the inflammation is also will be showing up higher metabolic activity. The inflammatory cells, macrophages, also will be showing higher metabolic activity. So this is very sensitive. In fact, it has become a gold standard to look for pyrexia of unknown origin. And in cardiology, it has been increasingly used to understand the cardiac viability before the any stenting procedures or even before the bypass procedures. And in neurology, it is being increasingly used in differentiate the type of the dementia and to understand the epileptogenic focus. So coming to the oncology purpose, with regards to the gastrointestinal malignancies, I'm just going to show some few slides how it exactly looks like. This is a case of a gastric malignancy where we are able to see mural thickening in the gastric pylorus, distal body and the gastric pylorus. The same side we are able to see the increased metabolic activity. So this is a whole body image showing up increased metabolic activity in the gastric lesion and no metabolic activity, metabolically active lesion in the liver, suggesting no distant metastasis. This is another example of metastasis of unknown primary. The patient presenting with left supraclavicular lymphadenopathy. Biopsy turned out to be an adenocarcinoma. So patient came for a PET scan, which showed this is what the findings are, like multiple lesions in the lung, multiple skeletal lesions. Finally, it narrowed down to a mass lesion in the cecum. It's a small lesion in the cecum which has thrown up so many metastases and which was proved by colonoscopy. And this is another area where the PET is being increasingly used in the case of a hepatocellular malignancy. But the thing is that it has got a variable degree of metabolic activity. Not all hepatocellular malignancies will be showing up higher metabolic activity. 40 to 50% of the lesions may not show metabolic activity, so we have to be very careful in interpreting such images. This is a case of hepatocellular malignancy, biopsy proven, not showing very high metabolic activity, it's just mild metabolic activity in the segment 5 lesion. This is a lesion here. This is another case where there were gastric erosions, weight loss, and hence a PET-CT was suggested. To our surprise, we were able to see it's a metastatic disease with multiple liver metastasis and peritoneal metastasis and primary from the liver, primary from the stomach. I would like to summarize in the for the staging purposes in GA malignancies, like most malignancies will be showing up higher metabolic activity. We have to be very careful. Like signet ring malignancies, mucin secreting malignancies will not be showing up higher metabolic activity. So we have to be careful in understanding whether are we dealing with a malignancy or non-malignancy. Hepatic malignancies can also show a variable degree of PET uptake. So in 50% of the times, we may not be showing up higher, it may not be showing up higher metabolic activity. In such a scenarios, we have to go by a CT criteria or an MRI criteria to understand how exactly the disease is. So coming to the next part, which is very important, is the response assessment scan. Many times, it becomes very difficult with a CT scan or an MRI to understand whether it is responding to the treatment or not, because the size will be remaining the same, the patient will be improving, but as a radiologist, I will not be in a position to say whether it is improving radiologically or not. In such a scenarios, PET comes very handy, and it gives complete information whether it is responding or not. This is because even before the morphological changes happen, that is whether the CT scan showing up reduction in the size or an MRI showing a reduction in the size, PET reduction in PET uptake happens much earlier and gives a better information and helps the clinicians to understand whether to continue with the same line of management or the management has to be changed. So this is an example of a pancreatic malignancy, inoperable malignancy, was put on chemotherapy. Post 3 cycles of chemotherapy showing up. This is a malignant lesion on the head of the pancreas. This is a follow-up PET scan shows. The lesion is looking the same. The size of the lesion is looking the same, whereas it shows a significant reduction in the metabolic activity, suggesting the patient is responding well to the treatment. This will be interesting to see. This is a case of an abdominal lymphoma, a large abdominal lymph nodal mass which is showing a very high metabolic activity. This is a lymph nodal mass which shows higher metabolic activity. During the interim PET scan, the lesion seems to be the same, whereas the PET uptake has come down significantly, suggesting it is responding very well to the treatment, and hence the same line of chemotherapy can be continued for the same patient. So this is a pre-treatment PET scan, whole body PET scan, and interim PET scan showing a good response, and the end of the treatment showing complete metabolic response to the treatment. And one another thing is that in the case of lymphoma, it has become a recommendation that the PET has to be performed even, during the staging purposes, and it has to be performed in the interim stage as well. The interim stage gives a good prognostic indication that if the metabolic activity goes down very much, then it says that the patient is going to have a very good prognosis. This is an interesting case. I just wanted to show that though the PET scan gives information much earlier, the CT scan picking up some information troubles the clinicians as well. It is showing a small hypotensive lesion on the liver, a CA colon patient, follow-up showing up post-resection and post-chemotherapy showing up a small hypotensive lesion in the liver. So he was perplexed, and the patient was referred for a PET scan, which showed no metabolic activity, suggesting it is just an abnormal THAD and not a metabolically active metastatic disease. So I would like to say that with regards to the colonic malignancies and rectal malignancies, and there are many data coming up saying that it is altering the management in close to 30 to 35% of the patients, and hence PET should be done in many patients to understand how the T status is and the nodal status is, and to understand the distant metastatic status as well. And another area where it is picking up, the PET CT is picking up, is the since the PET CT, as I said earlier, it is an anatometabolic information, anatometabolic imaging. The anatomic part is given by the CT, which has its own limitations. And hence, when the CT is being replaced with the MRI, when it becomes a PET MRI, that brings the best of the both worlds together. Like MRI gives the best anatomic information, and the PET giving the best physiologic information. When both these things to fuse together, we get good information with regards to the T status of any malignancy. This is a CT image showing a suspicious lesion in the ampullary region, whereas MRI is pretty clear that where the lesion is very clearly made out in the MRI. When PET and MRI are fused together, we get This is a metabolically active lesion in the periampullary region, which is showing, which is obstructing the CBD and which is well clearly made out. This is another example of a post-gastrectomy patient coming for a follow-up PET MRI, which showed there is a lesion sitting in the duodenal stump, this is in the region, the duodenal stump region post-gastrectomy, and which is showing metabolic activity. This is the region where interest is picking up for rectal malignancies, because for the T status, a definite, in almost all the cases, MRI is necessary to understand the T status, and PET is necessary to understand the distant metastatic status. When both these things are fused together, we get everything in a single go. Like there is a lesion in the rectum, we are able to see the rectum in the MRI. These are the MRI images, and since it is a T4 disease, which is extended outside, and it is infiltrating the mesorectal fascia, and this PET image shows increased metabolic activity in the lesion. So to sum up, I would say that it is being increasingly used, and it is very sensitive and very helpful in many situations to understand the staging of the malignancies, most of the malignancies, except for a few malignancies where it is going to be less avid. Rest of the malignancies is very helpful in understanding the T status, N status, and M status during staging purposes, and during the therapy response, and in the surveillance scans. I'd like to go up on the few slides on the other traces, which I just said initially, a gallium DOTA scan. And this is a case of a rectal neuroendocrine tumor. I would like to say that the FDG, it is not sensitive in picking up the, FDG PET is not sensitive in picking up the neuroendocrine tumors. There is the lesion is, we are able to see a lesion in the rectum, which is projecting on the left lateral aspect, whereas this is an FDG PET CT, shows no significant metabolic activity. Yeah, a DOTA PET CT is also performed in the same patient, which showed very high DOTA uptake in the rectal lesion, and there are multiple lesions in the liver which are showing high DOTA uptake. This is a whole body image, shows no obvious lesion in the liver in the FDG PET scan, whereas a DOTA PET CT shows it's studded with lesions. I'd like to make a point here that for the well-differentiated neuroendocrine tumors and the moderately differentiated neuroendocrine tumors will be DOTA avid, whereas if it is going to be a poorly differentiated neuroendocrine tumors, it would be better to go for an FDG PET and not the DOTA scan. This is another example of an insulinoma, which is a PET MRI, which shows a lesion in the pancreas and with multiple lesions in the liver. This is a case of a prostatic malignancy. I'll just skip those findings. So PET beyond oncology, it is being increasing, as I said earlier, it is being increasingly used in the case of pyrexia of unknown origin. This is a case of an ADPKD, which the patient has multiple renal cysts, and the nephrologists are perplexed to understand where exactly the infection is. So PET CT was performed. It showed the cyst in the left kidney showing higher metabolic activity, suggesting there is infection there, and it was drained, and the patient was fine over that. To summarize, I would say that PET CT and MRI gives excellent morphological and functional information in a single setting. And for neuroendocrine tumors and the carcinoids, DOTA PET CT is indicated that two predominantly well-differentiated and moderately differentiated neuroendocrine tumors. Thanks, sir. Sorry, this. You want me to continue with this one? Or?
So this is the PET CT of the patient we are discussing, and
this PET CT showed a lesion in the pancreatic head, which shows higher metabolic activity, and there is intrapancreatic segment CBD mural thickening, which shows increased metabolic activity, which was shown in the arrow, and the pancreas is showing diffuse metabolic activity and with dilated MPD, and there is a small cyst, probably pseudopancreatic cyst, in the distal aspect. This is a whole body PET image showing enlarged lymph nodes in the iliac region and the inguinal region with increased metabolic activity. In the same patient, there were metabolically active mild soft tissue thickening in the periorbital region on the right side, and there were metabolically active mural thickening surrounding the proximal segment of the left subclavian artery and the distal segment of the right subclavian artery. These were the areas where there were mural thickening, which showed increased metabolic activity, and these were coronal sections showing enlarged lymph nodes in the right external iliac region.
We see some now patients with IgG4 presenting with periarteritis also. I think that's a very important point.
Yes, sir.
That you made those lesions in the subclavian arteries.
Subclavian arteries.
Because I've seen patients with periarteritis, and even smaller blood vessels.
Yes.
One lady presented with severe abdominal pain.
Large and medium-sized
Medium
vessels.
size. That's a very important thing. The second thing is there's any specific, findings to say that in a PET CT, this is IgG4 and it is something else. I'm just asking you. People are working on that, but you're really aware of that or something.
This is not very specific
Very
enough
specific.
in understanding whether it is
Yeah.
an IgG4 disease. It just says that there is an active inflammation happening in these areas. As
So
such.
response to treatment only issues.
So how will you call it, sir? How to differentiate basically a malignancy or something else?
With all these findings in picture, since the discussion was going more towards pancreatic malignancies and sort of things, this lesion in the CBD pancreatic head, the type of the lesion, the type of the enhancement and the type of the narrowing of the CBD does not favor a malignancy. And added to that, if you're suspecting a malignancy, having lymph nodes in the iliac region and the inguinal region will not going to be of support. And mural thickening in the subclavian arteries and periorbital soft tissue thickening definitely is not going to be of any support to call it as malignancy.
Thanks, Surya Kumar. That is an excellent way of simply putting forward the PET CT. And this is our reports. Actually, what Surya Kumar picked up actually didn't picked up by our radiologist. This is a hypermetabolic lesion in uncinate and proximal body of pancreas, and mediastinal, periportal, right common, external iliac and inguinal nodes. So they missed out the vascular lesions. And so now the question to the PGs. So this is the PET CT. Now, what is the thoughts? They did a, we are coming, sir.
So there is, as Sir mentioned, there is hypermetabolic activity everywhere actually, in the pancreas, in the CBD, in the periorbital area. So the multiple sites of involvement, we take into more of IgG4 related disease because it can involve the periocular areas and the vascular periaortic area. Other possibility also can also consider lymphoma also. Like there is also increased uptake of hypermetabolic activity in lymphoma. With they say that lymph nodes are usually below the renal veins.
Surya Kumar, what about lymphoma?
The periorbital soft tissue swelling and the perivascular soft tissue thickening is not supporting lymphoma, whereas the lymph nodes only in the iliac region and in the inguinal region can support lymphoma. And the pancreatic lesion and the CBD lesions are not supportive of lymphoma. So we cannot have multiple differential diagnoses.
So what do you do next? So here is the patient with an obstructive jaundice with lesions in the pancreas nodes. Still we are not yet to, started on autoimmune pancreatitis, started on steroids, not responded to steroids. Progressive disease, developed jaundice now. That's where we are with the PET CT showing these kind of findings.
I think we should do tissue sampling in the form of either excisional biopsy from the inguinal node or axillary node, or we can do EUS and EUS guided FNB, fine needle biopsy from the pancreatic lesion. That will be the concept that can give the clues for the diagnosis.
Why can't an ERCP?
At present, patient is for basically ERCP for diagnostic and therapeutic purpose. For diagnostic purpose, we can get better information through EUS rather than doing cholangiography, and that too putting in the contrast and making him the risk for looking at the risk for cholangitis, and we can take the biopsy also through EUS. That's why not.
Any other thoughts?
you realize in the diagnostic criteria, I think exfoliative cytology is not a routine or an accepted mode of diagnosis for autoimmune pancreatitis. So you're justified in doing in US with FNB. You would need a good true cut or an US FNB biopsy, which is an accepted diagnostic criteria for autoimmune pancreatitis.
And only on the biopsy we can categorize according to Boston diagnostic criteria. On the biopsy specimen, more than 10 IgG cells per high power field should be there to tell it as an IgG4 related disease, if it is.
So what are the diseases you are? Because obviously it is not IgG4 disease. Otherwise we are not discussing. Because, so what are the diagnoses you think of? Okay, this is our oncologist advised because he thought it is a disseminated malignancy, and he advised, that is before he subject for ERCP and FNAC of the lymph node. And I request Dr. Vikram, so the FNAC of right external iliac lymph node was done. Before anybody can understand, read the slides. This is a lymph node, 2 slides I have. Anything obvious or nothing is there?
We can see, but we have no vision.
Even I don't.
Good evening, one and all. Okay.
Vikram also seeing for the first time, I think.
Okay, the smear is moderately cellular, and it's showing these, the dark ones which are small are the mature lymphocytes, and the purple ones which are larger with little open up chromatin, they are the maturing lymphocytes. So we are seeing lymphocytes in varying stages of maturation. And if you can see clearly, these are some dendritic cells in the background. So the smear is showing mixture of population with containing variable, lymphocytes in varying stages of maturation, which is a sign of reactive rather than a malignant one. Even this one here is a plasma cell. So we are saying mixed population of lymphocytes, which is a sign of reactive change rather than a malignant or a lymphoproliferative disorder.
See, so that is a reactive changes only in the lymph node. So I discussed, we did a brushing in the ERCP. These are the brushing slides. Anything you want to interpret? So what is the role of ERCP brush and biopsy? What is the statistics?
Sir, ERCP with brush cytology is usually 32 to 36% sensitive for malignancy. And if we take it, brushing is like that. And if targeted biopsy has been taken with spyglass, then the sensitivity increases to around 80 to 83%, sir.
Specificity?
Specificity is 100%.
Almost 90 to 95%.
Hit it, but you often miss it. But you often combine with ampullary biopsy, and if there is a previous stent, you can even do the stent cytology. Use the material from the previous stent.
Okay, this is a pap stain smear, and showing these yellow blobs are elements of bile constituents, and we are seeing few scattered cellular elements in the smear. Again, this is a hyperview of these cellular clusters, showing single layer of cells which are, in the periphery of the cluster, we could see some fence-like appearance of the cells which have orderly arranged nuclei in the base of the cell. These are benign ductal epithelial cells. No obvious malignant cells are seen in the smears, in the photographs of the smears.
So where are we now? So the only thing is, oncology is very sure that there is no malignancy, because the FNAC is the one thing which ruled out metastatic disease, because the FNAC is 100% sensitive for any metastatic disease. So he referred to me again back to, you take out the patient, manage the pancreatitis and cholangitis. And what should I do?
proceed with excisional biopsy of the superficial lymph node, like inguinal, and proceed with the US FNB actually, fine needle biopsy.
Otherwise, how to approach a lower CBD stricture? Not in this sitting, how to approach a lower CBD stricture?
Whether initially told that it's benign or malignant. If it's benign, look for the causes like stones, cold cyst, pancreatitis, autoimmune pancreatitis.
No, how to establish the diagnosis?
Yes, sir. Either we go for imaging, MRI and MRI for proximal.
So basically like this. So you do an abdominal ultrasound, differentiate into a proximal and distal obstruction. So we are confined to distal obstruction. Do a CT if there is any mass or no mass. Again, the distal obstruction, the UES is a very good role if there is no mass. Almost 40% of the patients, they can pick up mass by a endoscopic ultrasound. So if there is a mass, again, there is a difference of opinion between straight away going for a surgery or a USFNA. Again, as a gastroenterologist, we should insist there should be a tissue diagnosis before a surgery. Because almost 14 to 16% there is a change of pathological diagnosis if you do a USFNA. Whether there is a mass or no mass, you should undergo a USFNA. If there is again no malignancy, then you subject for an ERCP. Again, if ERCP is no malignancy, you consider other modalities that include spyglass, intraductal ultrasound, or confocal laser endoscopy. So these are the ways you approach a lower CBD stricture. So in this case, what is the next step?
So we have already done a CT.
So we have done a
it's a
CT,
distal
USFNA, ERCP, everything was done.
Other option is spyglass angioscopy with biopsy.
Where is the stricture?
Distal CBD stricture.
What is the problem with the spyglass? Because you saw my ERCP, that is very difficult to negotiate the lower CBD. So it is, you cannot enter your spyglass through that stricture. Plus a lower CBD stricture is very difficult to evaluate by a spyglass. So what is the thought? What is the next step? So what are these biopsies? What organ? Girish, you are right only. You can. Ashish, you are right only.
Lymph node, sir. It is lymph node.
So
Germinal center is there, sir.
I subject the patient for a lymph node biopsy, and any idea what is the disease? I'll put the markers also. Clue? What are these markers used for?
Immunohistochemistry, might be from lymphoma, CD3, Ki6, no, neuroendocrine tube.
Okay, as said, it is a section from a lymph node. And I could see two prominent things here. One, the follicles are of uniform size and they are seen entirely throughout the lymph node and not just restricted to the cortex as we would expect in a normal lymph node. Other thing is, we are not seeing any prominent sinuses in the medulla. So these are the two things that I could appreciate in this magnification. Nothing additional I'm getting in this image. And okay, this is a high power magnification and this is showing, I don't know whether you are seeing the same thing there. And we are seeing multiple layers of these darkly stained cells. These are the mantle cells which is surrounding the lymphoid which is surrounding the germinal center of a lymphoid follicle. In contrast to the darkly stained cells, these are pale germinal centers, and the thing to note here is the germinal centers are lacking or depleted of lymphocytes, and these mantle cells which are dark are arranged in concentric circles. And between the two follicles, the interfollicular area is showing these prominent vessels which also we don't see normally in a lymph node, and these vessels are containing some eosinophilic material, that is the pink stained material in their wall. These are the hyalinized vessels, and we could see a similar vessel within the germinal center of a lymphoid follicle. And again, one another lymph node, this is showing a characteristic finding of showing two germinal centers within a lymphoid follicle, which is called twining or twinning, and we could see a vessel which is entering or traversing radially through the mantle cell and entering the germinal center. The other findings are the same. You can see numerous vascular channels in the interfollicular region. And one of the prominent thing to note here is the interfollicular cells are not showing any clusters of plasma cells, since we are having a differential of IgG4 in the discussion. Again, this is what is called a lollipop lesion. There is one vessel which is seeing entering, that is like the stalk of the lollipop, and this is the lymphoid follicle, and this is the characteristic hyaline vascular lesion or a lollipop lesion. No additional information in this image. And again, nothing to add here. Only thing is we are not seeing any clusters of plasma cells, and this is the interfollicular area again in a higher magnification, showing these vascular channels which are hyalinized. Nothing new here. And this is one another lymphoid follicle showing a traversing vessel through its mantle. I don't know, K67 is not going to be of much use here. The CD3 and CD, the role of BCL2 here must be for differentiating it from a follicular lymphoma. In the typical expression of BCL2 is limited to the mantle layer. We don't find expression of BCL2 inside the germinal center in a normal lymph node. In a case of follicular lymphoma, there will be BCL2 expression. The expression means here is the brown color which you are seeing in the cells, that indicates that the cells are expressing the antigen. So if the lymphoid germinal center of the lymphoid follicle is expressing BCL2, then we will consider follicular lymphoma. Since this must have been done to rule out a follicular lymphoma. And CD23 is a marker of follicular dendritic cells, which you could see as a meshwork within the lymphoid follicles. All these like mesh-like network going inside the lymphoid follicles, that indicates the follicular dendritic cells within the follicles. So immunohistochemistry is not much helpful in this case. It's a morphological diagnosis, and it is characteristically hyaline vascular Castleman disease.
Isn't that a form of IgG4?
Hyaline vascular
Sir,
Castleman
form
disease.
of IgG4, Castleman's disease. Lymphoma, prediscuss. Here it is.
So,
It is a precursor of
so this is the disease I got. So suddenly when somebody is mentioning this kind of disease, we don't know what to do. So usually I have 2-3 people in Apollo, so we'll usually refer to them. So one is Dr. Ramakrishnan and another is Prabhu. And I call both of them, and Ramakrishnan, because this is one of the, what we are discussing is IgG4 disease. The Castleman's almost mimics an IgG4 disease. So Dr. Ramakrishnan, please enlighten us on both the disease.
Thank you very much, Hubal. I thought this is more a feast for thought, but it seems to be more feast for the palate. I think I should attend this monthly meetings. He keeps on giving me something to eat. In the process, I've started sleeping a little. Now, one important thing as far as, in fact, when this patient, I saw her first, I also thought very much in terms of IgG4 disease, because I jumped at the conclusion of her pancreatic disease and the IgG4 elevated to such high levels of heights. But what really troubled me was the fact that she was unresponsive to steroids, and that is something which should you bid you back. I do accept the fact that some people with IgG4 disease are unresponsive to steroids, where you may have to start them on rituximab, and I have had very good experiences with rituximab. But initially, IgG4 disease is something which melts with steroids. That's one important fact which made me feel that it is not IgG4. Now, we have to talk, just 5 slides. I'm not going to bug you too much about it. Now, if you take IgG4 disease, it's an immune-mediated fibro-inflammatory multisystem disease. And the basic pathology, you get like tumor-like swellings of the involved organs and organ dysfunction. Like invariably, people present with lacrimal gland enlargement, salivary gland enlargement. This is a very common presentation. In fact, people present even with pseudotumor of the orbit. Initially, they used to say this idiopathic inflammatory orbital disease. And later, when we started doing the histopathology and getting into it, well, Dr. Ashok will agree that people started picking up IgG4 disease. So usually it becomes like a tumor-like lesion. And if it is a tumor which is present in a place, it can either cause anatomical dysfunction or physiological dysfunction of the organ involved. It is associated with elevated serum levels, 135 milligrams per deciliter. Not everybody has got elevated serum IgG4, but the majority have elevated serum IgG4. An important point is serum IgG4 should always be estimated in an empty fasting. That's very important. You can't give it postprandial, that's important. Now, anyway, we have people, Dr. Ashok here. I can't talk about histopathology, but there are certain important features which are quite unique as far as IgG4 disease is concerned. You have a dense lymphoplasmacytic infiltrate, and it's rich in IgG4 positive plasma cells. And important is the ratio of the IgG4 positive plasma cells to total IgG positive plasma cells should be more than 40%, or at least per each high power field, you should get more than 10 IgG4 positive plasma cells. And this is very pathognomonic. They have a storiform fibrosis. That's why we call it as a fibro-inflammatory disease. The fact that there is fibrosis associated with dense infiltration with plasma cells and lymphocytes. Some of them do have a phlebitis, which is in fact pathognomonic of the disease, and some people even have eosinophilic infiltration over there. The response to treatment initially is very fantastic with steroids. We usually start as 1 milligram per kg body weight, go for about 4 weeks, and then we start gradually tapering down the steroids. And then they may reach a stage when they're off the steroids also. If we are among the 150 patients of IgG4 I've seen, and the majority of them invariably had involvement of the lacrimal glands and the salivary glands or the pancreas. But there are very peculiar situations. There is one patient who had IgG lesions in the skin. Histopathology showed IgG4, classical histopathology, but they didn't know it was IgG4. Later it came to the lacrimal gland enlargement. We were able to correlate, seen lesions with people in the hypothalamus, in the region of the pituitary. And then people, retroperitoneal fibrosis is a common one, which is people. And then aortitis, periaortitis, and even involving, we've seen people with involvement even of the superior mesenteric arteries and all that. So what I meant to say is, what we are now seeing is just the tip of the iceberg as far as IgG4 is concerned. So high degree of suspicion should always be entertained when people present this. Now, what is this Castleman's disease? Now, I'm treading into the area of a hematologist. I think Dr. Prabhu is there in the last row. He's come, yeah. He's a very nice chap. Usually he comes late to the OP, later than I, and so the meeting also I think he's come a little late. But he'll go late only, don't worry. Prabhu, you can join me because I think he's more competent to talk about Castleman. But just a few words about Castleman's disease, which I know from my point of view as a rheumatologist. I don't know like Prabhu, I'm sorry. It's a rare polyclonal lymphoproliferative disorder, so that's why we are fighting about this oligoclonal and polyclonal. It's very aggressive in nature if it is multicentric, and it has got an oncogenic potential of turning out into a lymphoma or a paraneoplastic pemphigus, especially when it is multicentric. And it is the greatest mimicry of IgG4 disease, related disease in the world. Multicentric Castleman's disease. Castleman's can be divided as monocentric or multicentric. Monocentric, just localized to one tissue. You do a surgical dissection, they are fine. Multicentric is something which I don't think even Prabhu would love to see because it's a very dangerous situation. And they have an elevation of serum IgG4 levels, and there is infiltration of IgG4 positive plasma cells in the histopathology. Now, I'm not going to talk about it. Pathologists are there. You have various types. Atropic, hypertrophic, sheet-like plasmacytosis is pathognomonic, and interfollicular plasmacytosis. And you have various 3 types like vascular, hyaline, and mixed. Now, why to distinguish between IgG4-related disease from multicentric Castle disease? Prognosis is different. I would like to have IgG4 disease rather than get into multicentric Castleman's disease. Treatment options are different. I shall tell you about it later. The mortality rate is higher in multicentric Castleman's disease. Oncogenic potential is great. IgG4 responds very well to steroids and rituximab, while in the contrary, multicentric Castleman disease responds better to ILC8 blockade like tocilizumab or cetuximab, and tocilizumab is available in the Indian market now. And the pathogenesis of IgG4 and MCD is different. This is a very important slide, the postgraduates. I'll definitely share the slides with them. You can take it off. IgG4 disease, the age of onset is usually beyond 50 years. Well, I'm at risk to develop IgG4. Castleman's disease is less than 50 years. Probably I should have developed it a long time ago. Orbital involvement, salivary gland involvement, lacrimal gland involvement, and pancreas involvement is common in IgG4-RD compared to Castleman's disease. History of atopy is common in IgG4. That's why you get serum IgG4 false positive elevation in people with atopic dermatitis. Splenomegaly is uncommon in IgG4-RD, but it is quite common in Castleman's disease. Lymphadenopathy is a little uncommon in IgG4 disease when compared to Castleman's disease, where it is quite common, very common presentation. Systemic symptoms, this is very, very important. IgG4 disease people are very well preserved. No problem at all. They look very fine. With lacrimal gland and salivary gland, they look very fine. But Castleman's disease, especially when it is multicentric, they are not quite fine. They have systemic symptoms. Elevated CRP is quite uncommon in IgG4. Its elevation is there common in Castleman's disease. Elevated IgA, I think that's a wrong word my secretary typed. Elevated IgA is more common in IgG4, uncommon in Castleman's disease. Polyclonal hypergammaglobulinemia is common in Castleman. The reason is for it being it's a very inflammatory disease. It is involved with the presence of interleukin-6. Nowhere hypergammaglobulinemia is more common in them. This is a point which I like to tell you, gentlemen, that IgG4 levels are significantly elevated in IgG4 disease, whereas serum IgG4 are elevated but may not be significant. But we have various exceptions to these rules. Histopathology is specific for either of them. Treatment, the drug of choice is steroids and rituximab, whereas when it comes to Castleman, it is IL-6, tocilizumab, or cetuximab. Nature, IgG4 is non-aggressive. Multicentric Castleman's disease can be aggressive. I just went through an article when there is a very rare presentation of a coexisting Castleman's disease associated with a pancreatic disease. I just picked it up. I will send these references to Ubal, which you can definitely share. Now the question is whether this person has got Castleman's disease or whether he's got IgG4 disease associated with Castleman. Is only an academic quarrel which we can have like in the parliament, but it doesn't make any sense. What we have to do is to treat the patient and not fight upon academic grounds. So this patient was treated with steroids earlier, which is unresponsive, and then we had to give her rituximab for the fact that she could not afford tocilizumab. She's doing excellently well in spite of the diagnosis and the treatment we offered. Thank you, Dr. Ubal.
I request Prabhu says.
And IgG4. This case was very interesting because although the histopathology of the lymph node showed Castleman's disease, there were a few things that were left to be explained. For example, the pancreas, the CBD stricture that was still left unexplained. So then we just looked for, in the literature, we've looked for cases where you could have both IgG4 and Castleman's disease. In such, then we found out that there are a set of conditions which, for example, in Castleman's disease, you can have raised IgG4 levels. And in fact, you can also get characteristic histopathology as like in IgG4 in Castleman's and lymph nodes. So then, like Sir summarized, there were a few very interesting differentiating factors. One is that IgA level. Castleman is a hyper-inflammatory condition, so you tend to have high immunoglobulin levels. You tend to have high CRP, etc. So those were the kind of differentiating feature. Castleman's belongs to a group of diseases called hyper-IL-6 syndromes. So you tend to have very high IL-6 levels. So in this particular patient, if you remember, I sent IL-6 levels, but I think it was high. I can't remember very well. So this is a very interesting case which probably falls right in the borderline between IgG4 disease and Castleman's. There are quite a lot of features going for Castleman's, especially the lymph node histology. But then there are certain features which goes against Castleman's, like the pancreas involvement, the CBD stricture, etc. So this is an interesting right in the middle kind of case.
So thank you, everyone. Thanks, Dr. Ashish and Girish. They presented excellently and discussed nicely. And thanks, Dr. Preeti and Basumani also. And this is the case, but what we learned is One is, if your secretary sends some patients, don't think that is a patient, that is a, send us an attender, don't think that is an attender, that may be a patient. And for the youngsters, somebody is referred for advanced malignancy and referred for a procedure, particularly for a metal stenting, don't be in a hurry to put a metal stent.
Umar, are you concluding?
I finished that then.
No, before that I want to ask Ramachandran a question.
Okay.
That's why I say that. This patient has gone through a terribly convoluted process and mentioned the tests in the world, she's gone through it. I just want to know from this guy whether Castleman disease can be diagnosed at least within a week.
Very good question. In such times, when you always pass on the buck to the other person. Dr. Prabhu, can you do that? Prabhu, come here. Yeah, your voice is quite loud, but still. Yeah, sir. And that is very shrewd. That's nice. We take Ashok.
So I think that is a problem of the specialization in medicine, sir, because I think this patient initially went to a gastroenterologist in Calcutta. I don't know whether that time she had a generalized lymphadenopathy or not. They missed out the finding. So they concentrate only on the pancreas and they document as autoimmune pancreatitis. That's why it was missed in the initial picture. The lymph node was picked up later when we saw here in Apollo. So otherwise, I think it is a lymph node biopsy, so straight away you can diagnose early.
I would just say that I think Vikram Raj really discussed the cytology really well, and that was important, and the histology too. The point to note is that the pattern of histology which was displayed showed more of what is called hyaline vascular type of Castleman's disease. It didn't look like the multicentric Castleman's disease, which is also known as the plasma cell type. Nor did it have enough features to warrant calling it a mixed type of Castleman's disease. The systemic Castleman's disease, which one encounters, usually it's the plasma cell type. That's one. Second thing is, going by what you said, there was a very good response to rituximab, you said? And that would, I think, would not be very much in favor of Castleman's. I'm not sure, but I think we have to ask Prabhu about that. And the other thing is, like you all mentioned, the involvement of the pancreas is unusual. If there's a node near it, that can be involved. And you can get extranodal lesions also in Castleman's disease. In fact, it was originally called a lymphoid hamartoma of the mediastinum by Dr. Castleman. So I'm not really sure whether we have a complete answer. Definitely there are morphologic changes in this node which would be consistent with Castleman's. I think it's again important to follow up and see how this patient progresses. Thank you.
Like Dr. Ashok.
I do accept the fact that one swallow does not make a summer, but I just thought I had this reference in the mind. Maybe.
I think this is definitely, it's very difficult to conclude as Castleman's because there are some features which is not characteristic of Castleman's. This right in the middle kind of disease. Like Sir said just now, Castleman's usually doesn't respond that well to rituximab also. Because we don't have anti-IL-6 antibody like siltuximab, etc., we tend to use rituximab, which has also been used in Castleman's. So I think, as Dr. Ashok said, we should have an open mind. We just have to see how this disease evolves. Maybe she's all right today. Maybe she might just present a year later with more lymph nodes and more unusual features.
So coming to that point of young patients referred for an ERCP, don't be in a hurry to put a metal stent and always try to establish the diagnosis. That is very important before you, because sometimes you are in a hurry to finish your procedure and that either you try to do an endoscopic ultrasound biopsy or a ERCP brush and biopsy. And third thing is the role of PET-CT in these kind of situations that will give an idea for what are the areas of involved. Are we dealing with a malignancy and not malignant conditions. The fourth thing is role of FNAC and versus biopsy of the lymph nodes. When we used to study that usually there will be FNAC not given much significant, we usually ask for an whole lymph node biopsy. Sometimes that is very, very useful like these kind of situations. And the final thing is, as we all discussed, that still the diagnosis in question, but we strongly believe that it's Castleman's disease involving the pancreas. As Dr. Ramakrishnan said, there are very few case reports involving the pancreas, and we pursue, because the patient not respond to steroids, and we believe that this is a Castleman's, and we are treating accordingly. Thank you, and I think Prem is not there, so I have to give the vote of thanks, and I thank all the senior members who religiously comes on the time, because I saw only the seniors is coming on 6:30. None of the, including the presenters, didn't come at 6:30. So that is very unfortunate, because we started 6:30 only because of the postgraduates. So please come, if somebody said 6:30, at least 6:50 you come and load the slides. If you find difficult, at least give the slides advance to me, I can load, and you can come on at least 6:30, please come on time. And I thank also Dr. Surya Kumar and Ramakrishnan Prabhu, because they helped a lot in concluding this CPC wonderfully. And I thank CIPLA for the wonderful organization, and I thank Crown Plaza also. Thank you, and please join us for the dinner.